بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we will continue inshallah the second part of this lecture about the spinal neoplasms. And you remember we have finished two items of this category. The first one was the bone tumors involving the vertebrae and the neural elements. Then we discussed the differential diagnosis of epidural pathology, and now we will continue with diagnosis of subdural lesions as well as the intramedullary lesions. You remember from the previous lecture that for the diagnosis of epidural or extradural lesion, you need to follow the CSF space on the side of the lesion. Then you will see that the CSF space as well as the spinal cord are compressed by the lesion. Then you know that this is an epidural pathology. Then, in order to diagnose the subdural lesions, you also follow the CSF space. Then you will notice that the CSF space as you approach the site of the lesion is getting wide. Either you are coming from above or you are coming from below. Then the CSF space on the side of the lesion, as you approach the lesion, it will be widened, and the spinal cord is compressed. So you know that this is a subdural pathology or an intradural extramedullary lesion. Then what is the differential diagnosis? There are two main pathologies here, the neurofibroma and the meningioma. Of course, other lesions can be seen in this place, but they are relatively uncommon, including hemorrhage in the subdural space, dermoid, epidermoid, arachnoid, as you remember, then metastasis. And metastasis can be seen here, especially the type known as metastatic CSF seed. Then starting by the neurofibroma, which is one of the common lesions seen in the subdural space. Neurofibroma has no sex predilection compared to the next common lesion, which is the meningioma, which is commonly seen in females. Also, neurofibroma do not usually show calcification, while meningioma may show calcium. Number 3, neurofibroma usually shows heterogeneous contrast enhancement, while meningiomas usually shows meningiomas show homogeneous contrast enhancement. Some of the neurofibromas can extend through the neural foramina into the extraspinal space, forming what is known as dumbbell-shaped configuration, and this is one of the character of neurofibromas, and this is not usually seen in cases of meningiomas. Also remember that neurofibromas are frequently be multiple, while meningiomas are uncommon to be multiple. And you see here a good example for a neurofibroma and the subdural space on the right side. The neurofibroma shows here homogeneous contrast enhancement. It is seen classically extending through the neural foramen into the paravertebral area, and the off-sagittal images can also the off-midline sagittal images can also show the neurofibroma extending through the neural foramen. This is typical appearance of neurofibroma in the spine, and you see part of the lesion is inside the spinal canal, part is extending through the neural foramen to form a paravertebral soft tissue mass, what's known as the dumbbell configuration. Then, in my opinion, this is the most typical appearance of a neurofibroma in the inside of the spinal canal. It looks like an oval-shaped structure, and this structure is not homogeneously enhanced. It will show a small area or areas of non-enhancing parts of the lesion, which is considered typical for this particular lesion inside of the spinal canal. Then if you look to the CSF space, and you can see that the CSF space is getting wide while you are approaching the lesion, indicating that this lesion is in the subdural space. The diagnosis of this case is extremely easy because the lesion is totally confined within the dural sac, and there is no cord here. Then you can see that there is a small lesion of low signal intensity in the T1 and T2 weighted images, and it shows homogeneous contrast enhancement. This lesion is intimately related to the coda equina nerve roots, and the diagnosis here is easy, as I have said. Then this is a neurofibroma, which is related to one of the lumbar nerve roots. Neurofibroma can be multiple, can be extensive in cases of neurofibromatosis, whether the type 1 or the type 2. And many times we can see this example where you are confronted by too many neurofibromas all over the whole spine. And the part of the neurofibromas are included within the spinal canal. Others can extend outside the canal through the nerve roots, while some of the neurofibromas can be totally outside the spinal canal along the nerve roots. Then you can see in the axial image widening of the neural foramina being occupied by heterogeneously enhanced soft tissue masses, and this is a very informative sagittal T2 weighted image of a case of neurofibromatosis in the lumbosacral area. And here, if you look to this case, which is a particular example or a peculiar example for neurofibromatosis involving every single neural exit foramen, starting from the cervical spine, ending into the sacral region, passing by the dorsal region. All these enhancing lesions inside the neural glands represent neurofibromas, and they are variable in size, being relatively bulky in the cervical spine as well as in the sacral area. They are relatively smaller in the dorsal region, as you can see. In the axial images, you can see the tumor with classic configuration, an intraspinal component and an extraspinal component extending through the neural foramen, and this can be unilateral or bilateral, as you can see in this very impressive example. Then we came to the meningioma, and meningioma is frequently seen in females. It usually contains calcium. Calcium is usually detected by CT. You know that MRI is less sensitive for calcium detection. Also, meningioma shows homogeneous enhancement. It can show the dural tail, which is not seen in cases of neurofibromas. It do not extend through the neural foramen, and it is less frequently to be multiple compared to the neurofibromas. In the T2 weighted image, the lesion shows intermediate signal. You are sure that this lesion is in the subdural space, because if you follow the CSF, it will get widened while you are approaching the lesion, either from above or from below, and you can see easily that the cord is compressed. And this is MR myelography showing the lesion compressing the CSF as well as the spinal cord. Then a meningioma, as I have said, will show homogeneous post-contrast enhancement. You can see the CSF space, as I have mentioned, and you can appreciate also the dural tail. And this is a meningioma inside the spinal canal showing intermediate signal in the T2 weighted images, homogeneous post-contrast enhancement, and this is the tumor by MR myelography. This is also another case of spinal meningioma, which is seen in the cervicodorsal region. In the T1 weighted image, the lesion showed intermediate signal. Also in the T2 weighted image, it shows intermediate signal, but after contrast injection, the lesion shows homogeneous post-contrast enhancement. And in the axial images, of course, you can appreciate also the intradural location of the lesion, but this can be more appreciated in the sagittal images. Meningiomas intradural meningiomas represent about 25% of the meningiomas in all over the body. 80% of these meningiomas can be seen in the dorsal region, 17% can be seen in the cervical region, and 7% in the lumbar region. This is a frequent location for meningioma near the foramen magnum or in the upper part of the cervical spinal canal. The lesion is of intermediate signal in the T1, relatively dark signal in the T2, and homogeneous post-contrast enhancement. And if you follow the CSF, you can see the sign I have mentioned. This is also a case of a subdural lesion, and this subdural lesion is diagnosed by widening of the CSF space on the side of the lesion while you are approaching the lesion either from above or from below. Then this lesion has no definitive criteria to support either the meningioma or the neurofibroma. It can be one of them. Then it's enough to say that this is a subdural lesion, and the differential diagnosis may include meningioma and the neurofibroma. Being homogeneously enhanced, you can suspect the meningioma, but you should remember that neurofibroma, whenever it is small, it will show homogeneous enhancement in most of the cases. Then in the subdural space, you can see lipoma, you can see epidermoid cyst, and you can see dermoid cyst as well as arachnoid cyst. Then this is lipoma because it shows high signal intensity in the T1 weighted image, and in the T2 weighted images it shows decreased signal, and in the fat suppressed image you can see suppression of the fat signal. This leptomeningeal metastasis or carcinomatosis is a lesion that is frequently seen in the clinical practice, especially in patients who have pathology in tumors in the CNS, and also this can occur from other lesions outside the CNS. The main diagnostic factor relies upon contrast injection. In these particular cases, you cannot diagnose leptomeningeal metastasis without injecting contrast media, whether by CT or by MRI. More better, of course, by MRI. And MRI is considered the most sensitive technique for detection of leptomeningeal metastasis, and the contrast injection is mandatory in order to diagnose these lesions. What's seen in the images after injection of contrast is the delineation of the borders or the margins of the spinal cord by continuous or interrupted very fine nodules that are enhancing in the post-contrast series. And this is almost similar to the sugar coating of these, as you can see in this figure, which is well appreciated after contrast injection. Before contrast injection, you may predict that there is some leptomeningeal lesions, but after contrast injection, you are sure that there are leptomeningeal nodules, and also you can see enhancement of the leptomeninges covering the distal part of the spinal cord. These lesions can be asymptomatic, they can be either focal or diffuse, as you can see here, and may be attached to the dura or the cranial nerves, and sometimes there is hydrocephalus associated in these conditions. Then if you look here and you see there is leptomeningeal metastatic lesions delineating the distal part of the spinal cord in this patient with breast cancer. You know that these lesions are frequently give metastasis via the CSF, including the medulloblastoma, ependymoma, and the pineal body germinoma. Other lesions can produce metastatic CSF seeds, and some of the lesions can occur outside the central nervous system, like the cases with breast cancer. And this is the female child with medulloblastoma. The cranial scans showed extensive leptomeningeal enhancement in the basal cisterns, in the sylvian fissures, in the interhemispheric fissure, in the choroidal fissures, as well as in the cerebellar folia. This is diagnostic of leptomeningeal CSF seed. The spinal images of the same case showed extensive leptomeningeal thickening with enhancing nodules starting from the craniocervical junction or the medullocervical junction, extending down to the terminal part of the conus medullaris. And you see thickened leptomeninges with nodular enhancement all through along the spinal cord, diagnostic of leptomeningeal enhancement. And then you have to differentiate between multiple neurofibromas, which are located in the subdural space, and the dural or leptomeningeal deposits, which are also located in the subdural space. But the difference is the neurofibromas are masses within the subdural space. They do not affect the surface of the cord, but these lesions are nodules, and you can appreciate easily that they are intruding inside the substance of the spinal cord. They are not located actually within the subdural space, but you see this thickened, enhanced leptomeninges, and you see the nodules that are impinging or insinuating themselves inside the substance of the spinal cord. This is the difference between both. And this finally we came to the intramedullary lesions, and intramedullary lesions will expand the cord. Then this is the situation where the cord is enlarged and the CSF space is attenuated. And you remember extradural lesions will compress the CSF and the cord. Subdural lesions will widen the CSF and compress the cord. Intramedullary lesions will enlarge the cord and attenuate the CSF space around the cord. There are two main lesions inside the substance of the cord. These are the ependymoma and the astrocytoma, which represent about 90% of the lesions occurring inside the substance of the cord. There are 10% of other lesions that are considered relatively uncommon compared to these two main entities. Then you can, if you see it, this is the myelographic image, which was commonly used before the era of MRI, and here you can see that the contrast column is markedly attenuated all around the cord, which is grossly expanded all over the cervical region, indicating the presence of an intramedullary pathology, but we are not sure about this pathology. Then we have the astrocytoma, which is considered the most common intramedullary tumor in the pediatric age group, and this lesion is commonly affecting the dorsal spinal cord, but frequently it can also be seen in the cervical region. This lesion is similar to the pilocytic astrocytoma, which is seen in the brain. This pilocytic astrocytoma, if you remember, is just a cystic lesion with an enhancing mural nodule. Then you see here a lesion which is grossly expanding the cervical spinal cord. The lesion appears cystic. It is of low signal in the T1 and high signal in the T2. After contrast enhancement, and you got enhancing nodule within the cystic component of the lesion. Then this is an astrocytoma of the cervical spinal cord. This is the enhancing part of the lesion, and you see a cystic component above and below the lesion. Then you remember that less than 2% of spinal astrocytomas are on the aggressive type or the glioblastoma multiforme. It is said that one of the characters of astrocytoma is to involve a long segment of the spinal cord, which may reach about 7 vertebral segments. And it is also well known that the cystic component surrounding the enhancing part of the lesion is part of the tumor. It is not a syrinx, for example. Then hemorrhage is uncommon, and syrinx formation is common in all types of intramedullary lesions. Then this is also an example of pilocytic astrocytoma. The cervical cord is expanded. It is occupied by a relatively low signal lesion in the T1, high signal in the T2. After contrast enhancement, the knee got enhancing solid part of the lesion with the cystic component above and below. And this cystic component, as I have said, belongs to the tumor itself. It is not a syringomyelia. Then ependymoma is, as the literature says, is a focal lesion, and it is usually limited to a lesser number of vertebral segments compared to the extensive appearance of the pilocytic astrocytoma. It arises from the ependymal cells inside the spinal canal and is considered one of the most common intramedullary tumors, and you see the percentage of incidence. It is known, it is well known from the literature that it is virtually impossible to separate astrocytoma from ependymoma based on imaging. And this is a rule that you can also use in the differential diagnosis. You may say that I am looking at an intramedullary tumor, which may be an astrocytoma or maybe an ependymoma. And factors favoring astrocytoma may be the younger age of the patient, maybe the cystic component and the solid component of the lesion, maybe the long segment of the spinal cord involvement by the tumor compared to the ependymoma. But you should remember that it may be impossible to separate the two lesions based on imaging. At some time I thought that the diffusion tensor imaging can help to differentiate between astrocytoma and ependymoma based on the fact that astrocytoma is a tumor of the substance of the spinal cord which will infiltrate the cord tracts, while the ependymoma is arising from the central spinal canal which will displace the tracts without invasion. But this thinking was not right. And according to the literature, we can divide the lesions inside the substance of the spinal cord into 3 types according to cord fiber involvement. The type 1 indicates that fibers of the spinal cord did not pass through the lesion. In type 2, some fibers are seen crossing the lesion, but most of the lesion do not contain fibers of the tracts. Type 3, fibers are completely encased by the tumor. And this is just an example of type 1. And this lesion is an intradural lesion based on the data I have mentioned before. And this meningioma, of course, will not involve the fibers of the spinal cord. It will just compress the fibers, as you can see here, and this is considered as type 1. Then I will give you some of the examples, but you should remember that tractography is not a way to separate between astrocytoma and ependymoma, and still the fact is there you cannot discriminate between both lesions based on imaging. Then if you look here, and this is a lesion inside the substance of the spinal cord in the T2 weighted image, and it is cystic, and it is pilocytic astrocytoma. Based on the tractography images, this lesion is seen splaying apart the fibers of the spinal cord, denoting a low-grade neoplasm or pilocytic astrocytoma with no evidence of infiltration of the fibers or destruction. Then this is an intermediate grade astrocytoma, also in the upper part of the spinal cord. Cystic lesion with a solid nodule, and the nodule has enhanced after contrast injection, and you can appreciate that there is some fiber implication within the tumor itself, denoting that this lesion is not a low-grade tumor, but it is relatively of an intermediate grade astrocytoma. This is an ependymoma, and in the ependymoma, it shows heterogeneous increased signal in the T2 weighted image with heterogeneous post-contrast enhancement, and you can appreciate that there is focal partial infiltration of the substance of the cord at the site of the lesion, and this indicates that this lesion is malignant and is infiltrating. Then the value of tractography is to predict the intramedullary lesion with it is a low-grade lesion without tract infiltration, or a high-grade lesion with tract infiltration, but it cannot separate between ependymoma and astrocytoma. The ependymoma affecting the conus is a lesion that can be easily predicted based on imaging. And then if you see a lesion like this one, which is of heterogeneous increased signal in the T2 weighted image and heterogeneous post-contrast enhancement, you may say that this is a conus ependymoma. Also, ependymoma of the phylum terminal can be predicted from imaging, and this is I think an easy diagnosis. If you see a mass in the lumbar region expanding in the spinal canal and scalloping the vertebral bodies, and this mass is of low signal in the T1 and the relative increased signal in the T2 and the strong heterogeneous post-contrast enhancement, and you may predict that this is a phylum terminal ependymoma. And this is also a pediatric example for a phylum terminal ependymoma, where the lesion shows some areas of hemorrhage being of high signal in this T2 in this T1, and the heterogeneous increased signal in the T2 weighted image, and you see this non-uniform pattern of contrast enhancement. The lesion is expanding in the spinal canal, and it may indent the posterior aspect of the vertebral bodies. Then if you see a lesion intramedullary, and this lesion has a cystic component and a solid component, then the differential diagnosis will include the ependymoma, the pilocytic astrocytoma, and the hemangioblastoma. In cases of ependymoma, this cystic component do not belong to the tumor. It is just a syrinx inside the spinal canal, and the tumor is this one. But in cases of pilocytic astrocytoma, the whole lesion is the tumor, and this cystic component is part of the neoplasm. And this is the same case in cases of hemangioblastoma. This is a case of ependymoma, which affects the cervical spinal cord in about 45% of cases, and the lesion may extend to involve the upper part of the dorsal spinal cord. And this lesion shows a cystic component with a solid heterogeneously enhancing component after contrast injection. It shows high signal in the T2 weighted images, and it causes focal expansion of the spinal cord. And these tumors may have the tendency to bleed, leading to the formation of subarachnoid hemorrhage. And you remember that the cystic part of the tumor is not belonging to the tumor itself. And this is an ependymoma in the lower part of the cervical region, and it is not well appreciated in the T1 weighted image, and it is appreciated after contrast injection. The high signal above and below the tumor is the cystic syrinx formation inside the spinal canal, which do not belong to the tumor itself. Then we have the remaining 10% of intramedullary lesions, which include the hemangioblastoma, the metastatic deposits, lymphoma, dermoid, epidermoid, and some of the inflammatory lesions like hydatid cysts, sarcoidosis. You remember this sarcoid, TB, and bilharziosis. I have explained these lesions in the sector of spinal infection, and also you can remember the presence of MS plaques inside the substance of the spinal cord. Then hemangioblastoma as a tumor may represent about 1 to 2% of the primary intracranial neoplasms. It can represent 10 to 20% of neoplasms in patients with von Hippel-Lindau syndrome. This lesion is usually seen in adults, and its main location is in the cerebellar hemisphere, and some of the lesions can be seen in the spinal cord. The lesion can be solitary, can be multiple. It is almost similar to pilocytic astrocytoma. There is a cyst with an enhancing mural nodule, and the nodule is a vascular lesion that will show tumor blush on angiography. And this is a case of multiple hemangioblastomas in a patient with von Hippel-Lindau syndrome, and you see about 3 lesions, and this angiogram shows that there is a tumor blush of this big lesion on angiography diagnostic of hemangioblastoma. And I hope you remember that for the diagnosis of von Hippel-Lindau syndrome, you may have one of 3 possibilities. A patient having multiple hemangioblastomas, either in the brain or in the spinal cord, or both. Or the patient have a single hemangioblastoma with positive family history of hemangioblastomas or von Hippel-Lindau syndrome. Or there is a single hemangioblastoma with visceral tumors. Then you see in this particular example, and I have shown it before, you can see 3 hemangioblastomas in the cerebellum. There is a cystic with 2 enhancing mural nodules, cystic lesion with 2 enhancing mural nodules, another one, and a third one. And you remember that the nodule may be large enough to occupy the whole cavity of the cystic component. Then we came to intramedullary metastases. They are diagnosed by the presence of a non-primary malignancy. This patient had melanoma, and you can see a lesion inside the vertebral body, number 2, and a lesion inside the conus. This lesion in the conus is of intermediate signal in the T1, high signal in the T2, heterogeneous post-contrast enhancement. And you see that this is not a hemangioma because the appearance of the lesion in the T2 weighted image is not bright. You remember that hemangioma will be so bright in the T2 weighted image to approach the signal of the CSF. Then this patient had the ovarian cancer with an intramedullary lesion, and this lesion expands the substance of the spinal cord, and it shows heterogeneous increased signal in the T2 weighted image with diffuse cord edema above and below the site of the lesion. After contrast enhancement, you see almost homogeneous post-contrast enhancement. The presence of a non-primary with an intramedullary lesion is suggestive of metastatic disease. And this is also a spinal cord metastasis, and you can reach the diagnosis by the presence of other metastatic deposits in the rest of the vertebral bodies. And there is a lesion here which is better seen after contrast injection with fat suppression inside the substance of the cord. On the contrary to the metastatic deposits in the spinal, in the vertebral column, I said that these lesions are well appreciated in the T1 weighted images without contrast injection. But in this case, if you have fat suppression, you may be able to detect the lesions, but they are already seen in the pre-contrast scans. And this is a patient with breast cancer, and you can see a lesion inside the substance of the cord with diffuse cord edema above and below the site of the lesion. This patient had breast cancer, as I have said, with liver metastasis, and she developed an intramedullary metastatic deposit. Then for the diagnosis of intramedullary lymphoma, you should know that the patient had lymphoma, and this is an example. The lesion is not well appreciated in the T1 and also after contrast enhancement, but you can appreciate the lesion inside the substance of the upper part of the cervical spinal cord and the T2 weighted images. You know that MS plaques can occur intracranially as well as in the substance of the spinal cord, and these MS plaques will show intermediate signal in the T1. They are not well appreciated in the T1. They are appreciated in the T2 weighted image, and if they show contrast enhancement, and this indicates active disease. Then finally, intramedullary serings, which means that there is a cavity inside the substance of the spinal cord. As you can see here, there is a diffuse low signal cavity involving most of the cervical and upper dorsal spinal cord. And the pathology of the development of this serings inside the spinal cord is not well known. There is alteration of the CSF flow at the base of the skull, or abnormal CSF pressure, and this pressure will be transmitted to the central spinal canal. We do not know how this can occur. It will result in dilatation of the central spinal canal, and we have three types of syringomyelia. The type number 1 is the serings communicating with the fourth ventricle with hydrocephalus caused by obstruction distal to the outlet foramina of the fourth ventricle. And the second type is dilated central spinal canal not communicating with the fourth ventricle, as in cases of Chiari, intradural tumors, arachnoiditis, and the canal stenosis. The third type is just a damage to the substance of the spinal cord secondary to trauma, infection, or ischemia, leading to the development of an area of myelomalacia inside the substance of the cord, which will form a localized serings. Thank you very much. Alhamdulillah Rabbil Alameen.